Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 266 of our pharmacotherapy series, which majors in tuberculosis. The first question reads, HTG is a 35-year-old Hispanic man who presents with a 4-week history of a productive cough. The cough was initially non-productive but became productive of yellow sputum after 2 weeks. The patient has been self-medicating with over-the-counter antitussives without relief, and he experienced hemoptysis this morning. He complains of subjective fevers, chills, night sweats, dyspnea on exertion, fatigue, and an unintentional 15-pound weight loss during the last 2 months. He immigrated to the United States from Mexico when he was 12 years old, but he has not traveled outside the United States for more than a decade. He currently works as a laborer on new home construction projects, and several of his co-workers, who moved to the United States from Mexico within the past year, have similar respiratory symptoms. He is currently married with 3 children. The patient has a 20-pack-year smoking history and drinks alcohol on weekends but denies illicit drug use. On physical examination, HTG is a thin-appearing man in mild respiratory distress. His heart rate is 94 beats per minute, his respiratory rate is 24 breaths per minute, and his temperature is 38.9 degrees Celsius. Bronchial breath sounds are noted in the right upper lobe on chest auscultation, and chest radiography shows extensive patchy infiltrates in the right upper lobe. Significant laboratory data include the following. White blood cell count is 13,200 per microliter, with 72% polymorphonuclear leukocytes, 3% bands, 12% lymphocytes, and 13% monocytes. Red blood cell count, 3.7 times 10 power 6 per microliter. Hemoglobin is 11.2 grams per deciliter. Hematocrit is 34%. Platelets, 269 times 10 power 3 per microliter. Serum electrolytes, renal function, and hepatic function are within normal limits. He is 69 inches tall, and his weight is 68 kg. The remainder of his physical examination is unremarkable. What signs and symptoms consistent with active TB disease are present in HTG? HTG's history of cough, which gradually became productive, fever, night sweats, fatigue, and weight loss are classic symptoms of active TB. Cough may be non-productive early in the course of the illness, but with subsequent inflammation and tissue necrosis, sputum is usually produced and is key to the diagnostic studies. Sputum may contain blood, also known as hemoptysis, in patients with advanced cavitary disease, which is particularly worrisome because cavitary lesions harbor high concentrations of organisms and the pulmonary location facilitates airborne transmission. Dyspnea is unusual unless there is extensive disease. Other symptoms of TB may include pleuritic chest pain and general malaise. In pulmonary TB, the chest radiograph usually reveals patchy or nodular infiltrates in the apical or posterior segments of the upper lobes, but changes may be observed in any segment. The patchy infiltrates on HTG's chest radiograph are consistent with pulmonary TB. Cavitary lesions may be seen, however, these were absent in this patient. Moderate elevation of the white blood cell count with increased monocytes and eosinophils and anemia are the most common hematologic manifestations of TB. HTG had an elevated white blood cell count with increased monocytes, and he was also anemic. Many patients with active pulmonary TB have no acute symptoms, and a lack of symptoms may hinder diagnosis. In one study, approximately 50% of active TB cases without classic symptoms were misdiagnosed. More than one-third of the patients with active TB had no sweats, chills, or malaise, and fewer than 50% were febrile. Cough was evident in 80% of these patients, and only 25% had hemoptysis. Although dullness over the apices of the lungs and post-tussive rales are expected in TB, less than one-third of these patients had any abnormal pulmonary signs. Similar findings were reported in another study. Absence of specific clinical symptoms underscores the importance of skin testing, sputum smears for acid-fast bacilli, and chest radiographs in suspected TB. Lastly, cases of active TB are often found after routine chest radiographs for other illnesses. Because many of the symptoms of TB also occur in persons with pre-existing pulmonary disease or pneumonia, they may be overlooked and not attributed to TB. The next question reads, what risk factors for TB are present in HTG? The close contact with his coworkers, who have similar respiratory symptoms, and the geographic origin from Mexico are risk factors for TB in HTG. In addition, studies have implicated cigarette smoking as a risk factor for TB. In a cohort study conducted in Taiwan, smoking was associated with a twofold increase in the risk of active TB. Furthermore, a significant dose-response relationship was identified for number of cigarettes smoked per day, number of years of smoking, and number of pack years smoked. Smoking impairs mucociliary clearance, decreases phagocytic pulmonary alveolar macrophage function, decreases intracellular production of tumor necrosis factor alpha, and causes iron overload in macrophages. These defects in host defense mechanisms increase the risk of active disease after exposure to Mycobacterium tuberculosis. A tuberculin purified protein derivative, abbreviated as PPD, skin test, 5 test units is ordered and placed on the volar aspect of his left arm. Sputum is collected and sent for AFB stain, culture, and susceptibility testing. His smear is positive for AFB, and the result of the tuberculin skin test, read at 48 hours, was a palpable induration of 14 mm. What is tuberculin PPD skin testing? How should the result be interpreted in HTG? The tuberculin skin test, also known as the Mantoux method, has been used as a diagnostic tool for infection with Mycobacterium tuberculosis for decades, but a positive skin test is not necessary for the diagnosis of active TB disease. The test is frequently referred to as the purified protein derivative test, which contains a protein prepared from a culture of the tubercle bacilli. Skin testing is performed by injecting 0.1 ml of solution containing 5 Tu of PPD intracutaneously into the volar or dorsal surface of the forearm. The injection is made using a 1/4 to 1/2 inch, 27 gauge needle and a tuberculin syringe. The solution should be injected just beneath the surface of the skin, avoiding subcutaneous tissue. A discrete pale elevation of the skin, a wheal 6 to 10 mm in diameter, is produced when the injection is performed correctly. If the first injection was administered improperly, another test dose can be given at once, selecting a site several centimeters away from the original injection site. If the patient has been infected with Mycobacterium tuberculosis, sensitized T cells are recruited to the skin site where they release cytokines. These cytokines induce an induration raised area through local vasodilatation, edema, fibrin deposition, and recruitment of other inflammatory cells to the area. Typically, the reaction to the tuberculin protein begins 5 to 6 hours after injection with maximal induration observed at 48 to 72 hours. Therefore, the test should be read between 48 and 72 hours after injection because tests read after 72 hours underestimate the actual size of the induration. For standardization, the diameter of the induration should be measured transversely to the long axis of the forearm and recorded in millimeters. The diameter of the induration should be measured and not the erythematous zone surrounding the induration. An induration of at least 5 mm in diameter read 48 to 72 hours after injection is a positive reaction in an individual with a recent history of close contact with a person with active TB, a person with fibrotic changes on chest radiograph consistent with previous TB, organ transplant patients and other immunosuppressed patients receiving the equivalent of equal to or more than 15 mg per day of prednisone for longer than 1 month, or HIV-infected persons. An induration of at least 10 mm in diameter is a positive reaction with clinical conditions associated with increased risk for TB, such as diabetes mellitus, silicosis, chronic renal failure, malnutrition, leukemia, lymphoma, gastrectomy, jejunoileal bypass, and weight loss of greater than 10% of ideal body weight. In addition, an induration of at least 10 mm is considered to be positive in recent immigrants less than 5 years ago from countries with a high prevalence of TB, injection drug users, residents and employees of high-risk congregate settings e.g., prisons, nursing homes, homeless shelters, healthcare workers, mycobacteriology laboratory personnel, and children younger than 4 years of age or infants, children, and adolescents exposed to adults in high risk. The skin test is also considered positive for persons with an increase in induration diameter of at least 10 mm within a 2-year period. For individuals with no risk factors for TB, an induration of at least 15 mm is required for a positive reaction. It is very likely that HTG has been in close contact with persons with active TB, that is, his coworkers, even though they have not yet been diagnosed with active TB. When all factors are considered, the PPD of 14 mm should be considered to be positive in HTG. The next question reads, because HTG's PPD skin test is positive, does this confirm his diagnosis of active TB? What other laboratory tests may be performed to aid in the diagnosis of TB in HTG? HTG's positive reaction to 5-TU of PPD alone does not imply active TB disease. It only confirms that he has previously been infected with M. tuberculosis. To confirm the diagnosis of active TB disease in HTG, Mycobacterium tuberculosis must be detected and isolated from sputum, gastric aspirate, spinal fluid, urine, or tissue biopsy, depending on the site of infection. As was performed in HTG, detection of AFB in stained sputum smears examined microscopically should be the first test to confirm the presence of mycobacteria in a clinical specimen. It is the easiest and fastest procedure that can be performed and allows preliminary confirmation of the diagnosis. Sputum samples for AFB stain and culture are best obtained early in the morning on at least 3 separate days. The cough reflex is usually suppressed at night, and the first early morning expectoration represents secretions accumulated in the chest overnight. The number of organisms in the morning sample is greater, and the diagnostic yield is higher. Smears may be prepared directly from clinical specimens or from concentrated preparations by placing the specimen on a glass slide under a microscope with a Zeil-Nielsen or fluorochrome stain, not a gram stain. Sensitivity of sputum smear microscopy is low because 5,000 to 10,000 bacilli per milliliter of specimen must be present for AFB detection in stained smears. Therefore, a negative AFB smear does not rule out active TB disease, and patients with active TB and negative AFB smears may facilitate transmission of Mycobacterium tuberculosis. Additional limitations of the AFB smear are its inability to differentiate among mycobacterial species and between viable and non-viable organisms. In many areas of the United States, Mycobacterium avium complex organisms are commonly isolated from the sputum of patients in whom a diagnosis of TB is highly probable, such as the elderly and patients with HIV infection. This finding has resulted in a marked decrease in the specificity and positive predictive value of the sputum smear, in some cases to as low as 50%. The gold standard for laboratory confirmation of TB is culture. Some patients may have a negative AFB smear, but a sufficient number of organisms may be present to produce a positive culture. Only 10 to 100 organisms are needed for a positive culture. As a result of the limitations of the AFB smear, a positive culture for Mycobacterium tuberculosis is necessary to definitively diagnose TB in HG and all patients, even if the AFB smear is positive. In addition, culture allows for genotyping and susceptibility testing of the isolate. Because Mycobacterium tuberculosis grows slowly, i.e., once every 24 hours, it may take several weeks for the cultures to become positive. Broth-based culture systems such as BACTEC, MGIT, MB, BACT, SEPTI-CHECK, and ESP, when combined with DNA probes, can result in positive cultures in 2 weeks or less for sputum smear-positive specimens and in 3 weeks or less for smear-negative specimens. Nucleic acid amplification tests are available to enhance and expedite direct identification of M. tuberculosis in clinical specimens independent of mycobacterial culture. These tests amplify the specific target sequences of nucleic acids in Mycobacterium tuberculosis that can be detected by a nucleic acid probe within 24 to 48 hours. 2 nucleic acid amplification tests are approved by the Food and Drug Administration (FDA) for use in the United States. The Enhanced Amplified Mycobacterium tuberculosis direct test is approved for detection of Mycobacterium tuberculosis in AFB smear-positive and smear-negative respiratory specimens. The sensitivity of this test is greater than 95% for patients with AFB-positive smears and 75% to 90% for patients with AFB-negative smears. The AmpliCor Mycobacterium tuberculosis test is approved for detection of M. tuberculosis in AFB smear-positive respiratory specimens. Sensitivity of the AmpliCor test is greater than 95% for patients with AFB-positive smears and 60% to 70% for patients with AFB-negative smears. Specificity of the nucleic acid amplification tests is greater than 95% for both AFB smear-positive and smear-negative pulmonary specimens. Compared with AFB smears, additional benefits of nucleic acid amplification testing include the ability to rapidly confirm the presence of Mycobacterium tuberculosis in a majority of patients with AFB-negative smears and the positive predictive value of greater than 95% for AFB-positive specimens in settings where non-tuberculous mycobacteria are common. Nucleic acid amplification tests are cost-effective because they prioritize contact investigations, improve decision-making regarding respiratory isolation, and decrease unnecessary TB treatment. Current guidelines recommend nucleic acid amplification testing on at least one respiratory specimen from a patient with signs and symptoms of pulmonary TB for whom a diagnosis has not been established and for whom the test result would alter case management and infection control activities. If the nucleic acid amplification result and the AFB smear result are positive, the patient is presumed to have TB, and drug treatment should be initiated while awaiting culture results. If the nucleic acid amplification result is positive and the AFB smear result is negative, clinical judgment should be exercised regarding initiating drug therapy, and additional diagnostic testing may be needed. If the nucleic acid amplification result is negative and the AFB smear result is positive, a test for inhibitors should be performed and an additional specimen should be tested with nucleic acid amplification. Sputum specimens 3% to 7% might contain inhibitors that prevent or reduce amplification and cause false negative nucleic acid amplification results. If the nucleic acid amplification result and the AFB smear result are negative, clinical judgment is recommended in the decision to begin drug therapy because nucleic acid amplification tests lack the sensitivity in AFB smear negative specimens needed to exclude the diagnosis of TB. The next question reads, would a negative tuberculin skin test have eliminated the possibility of infection with Mycobacterium tuberculosis in HTG? A negative response to 5-TU of PPD in HTG would not exclude active infection with Mycobacterium tuberculosis. The PPD skin test has a reported false negative rate of 25% during the initial evaluation of persons with active tuberculosis. This high false negative rate is attributable to poor nutrition and general health, overwhelming acute illness, or immunosuppression. False negative results usually occur in persons who have only recently been infected or are anergic. Anergy, the decreased ability to respond to antigens, may be caused by severe debility, advanced age, immaturity in newborns, high fever, sarcoidosis, corticosteroids, immunosuppressive drugs, hematologic disease, HIV infections, overwhelming TB, recent viral infection, live virus vaccinations, and malnutrition. If anergy is suspected, control skin tests Candida, mumps, or trichophyton may be placed in the contralateral arm. If the control test results are positive and the PPD test result is negative, infection with M. tuberculosis is less likely. The Centers for Disease Control and Prevention (CDC) changed its recommendations regarding anergy skin testing in HIV-infected patients with a negative PPD. They cite problems with standardization and reproducibility, a low risk for TB associated with a diagnosis of anergy, and the lack of apparent benefit of therapy for latent TB infection in anergic HIV-infected patients. Therefore, the use of anergy testing in conjunction with PPD is no longer routinely recommended in this population or other patients who are immunocompromised. The next question reads, on further questioning, HTG informs the medical team that he received the BCG vaccine when he was a child in Mexico. What is the BCG vaccine? What effect does the BCG vaccine have on the results of the tuberculin skin test? What other test may be performed in HTG for detection of Mycobacterium tuberculosis infection? BCG, or Bacille calmette-guerin, is a live vaccine derived from an attenuated strain of Mycobacterium bovis, and it is used in many foreign countries with a high prevalence of TB to prevent the disease in persons who are tuberculin negative. Many different BCG vaccines are available worldwide, and they differ with respect to immunogenicity, efficacy, and reactogenicity. Additional factors, such as genetic variability in the vaccinated subjects, the nature of the mycobacteria endemic in different parts of the world, and the use of different doses and immunization schedules, may contribute to the varied degrees of protection provided by the vaccine. The protective effect derived from BCG vaccines in case control studies ranges from 0% to 80%. Two meta-analyses calculated estimates of the protective efficacy of BCG vaccination for preventing TB. Results from the first meta-analysis indicated a 75% to 86% protective effect against meningeal and miliary TB in children. In the second meta-analysis, the overall protective effect of BCG vaccines was approximately 50%. Vaccine efficacy was higher in studies in which persons were vaccinated during childhood in contrast with those vaccinated at older ages. Unfortunately, neither study could confirm vaccine efficacy for preventing pulmonary TB. Prior vaccination with BCG usually results in a false positive tuberculin skin test in patients who are not infected with Mycobacterium tuberculosis, but skin test reactivity does not correlate with protection against TB. There is no reliable method of distinguishing tuberculin reactions caused by BCG vaccination from those caused by natural mycobacterial infections. Therefore, it is prudent to consider positive reactions to 5-Tu of PPD in BCG-vaccinated persons as indicating infection with Mycobacterium tuberculosis, especially among persons from countries with a high prevalence of TB. Even though HTG received the BCG vaccine when he was a child, the results of the PPD skin test should still be considered positive, especially in light of his symptoms. In general, BCG vaccination is not recommended for routine prophylaxis in the United States because the risk of exposure to TB is relatively low. BCG vaccination should be considered only for very select persons who meet specific criteria and in consultation with a TB expert. BCG vaccination should only be considered for infants or children who are PPD negative and are continually exposed to a highly infectious, untreated patient with active TB or a child who is continually exposed to a person with infectious pulmonary TB caused by Mycobacterium tuberculosis strains resistant to isoniazid and rifampin. BCG vaccination of healthcare workers should be considered on an individualized basis in settings in which a high prevalence of patients is infected with MDR-TB. Transmission of MDR-TB strains to healthcare workers and subsequent infection are likely, and comprehensive infection control precautions have been unsuccessful. BCG vaccination is contraindicated in pregnancy and in persons who are immunocompromised, e.g., HIV infection, or persons who are likely to become immunocompromised, e.g., organ transplantation. Adverse reactions to the BCG vaccine vary according to the type, dose, and age of the vaccine. Osteitis, prolonged ulceration at the vaccination site, leukoid reactions, regional suppurative lymphadenitis, disseminated BCG infection, and death have been reported. An interferon gamma release assay abbreviated as IgRA is preferred over the tuberculin skin test for persons who have received the BCG vaccine. Two interferon gamma release assays are currently approved by the FDA as an aid for diagnosing both latent and active Mycobacterium tuberculosis infection, the QuantiFERON TB Gold test and the T-Spot TB test. These interferon gamma release assays assess response to synthetic peptides that represent specific proteins, early secretory antigenic target 6, abbreviated as ESAT6, and culture filtrate protein 10, abbreviated as CF-P10, that are present in all Mycobacterium tuberculosis strains. In sensitized patients, ESAT6 and CF-P10 are recognized by T cells and stimulate release of interferon gamma. The quantiferin TB Gold test measures the interferon gamma concentrations released using an enzyme-linked immunosorbent assay. The T-Spot TB test uses an enzyme-linked immunospot assay, abbreviated as ELI-Spot, to detect increases in the number of cells that secrete interferon gamma. However, ESAT6 and CF-P10 are not present in BCG vaccine strains and most non-tuberculous mycobacteria. Therefore, interferon gamma release assays have improved specificity in BCG vaccinated persons compared with the Tuberculin skin test. Results are available within 24 hours compared to 2 to 3 days for Tuberculin skin testing. The next question reads, should HTG be tested for HIV infection? The CDC recommends HIV screening for all patients with TB as well as those persons suspected of having TB disease and contacts of patients with TB. Therefore, HTG should be tested for HIV. HIV infection is the most important risk factor for progression of latent TB infection to active disease, and progression is more rapid in HIV-infected persons. Unlike other AIDS-related opportunistic infections, CD4 count is not a reliable predictor of increased risk of TB disease in HIV-infected persons. TB may be the first manifestation of HIV infection because patients can have a relatively high CD4 count when TB disease develops. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 267.